Hello students, welcome to the discussion of the questions and the topic is CNS disorders in the pediatrics. So first we say here the question, a 19-year-old girl presents with headache, unsteadiness and poor hearing that has worsened over the past 5 years. Her father's medical history includes some type of brain surgery and he has been deaf since the age of 35 years. Renal functions are normal, the most likely diagnosis is. So basically, if we consider here, there is presence of hearing loss. That was in the father also, that is in the daughter also. Now, if we consider out of these choices, in neurofibromatosis type 2, there are vestibular schwannomas, which we also call as acoustic neuromas. Acoustic neuroma, and this can very well be associated with unsteadiness and poor hearing. And neurofibromatosis 2 is an autosomal dominant disease. An autosomal dominant disease can arise any time, can arise any time up to adulthood, up to adulthood. So father was also having the same thing. The same thing can come in the daughter also, autosomal dominant disorder, right? Basically vertical transmission. So the right answer is neurofibromatosis 2. Optic gliomas are seen in NF1. Tuberous sclerosis as such, there is nothing which can cause hearing loss, and here it is being given renal functions are normal. So in all the Alport syndrome there can be hearing loss, but as the renal functions are normal, this is ruled out. Going on to the next question, which of the following is a characteristic feature of the JME, juvenile myoclonic epilepsy? What we all know, the seizure occurs early morning. Seizure occurs early morning in a teenage child between 12 to 18 years of age. 12 to 18 years of age. The drug of choice is sodium valproate and that is given lifelong. That is given lifelong. The child on examination is absolutely normal. So the right answer is this one out of the choices. Complete remission, no. The child is totally normal, particularly neurological examination. Next one, 8-year-old presents with low-grade febrile illness and irritability for 3 weeks, progressively increasing drowsiness for the past 5 days, multiple episodes of GTCS for the 3 days. So everything so-called irritates, irritability, drowsiness, generalized seizures. This is particularly all are the features of the CNS infection, right? Moreover, examination reveals the child to be with decreased level of consciousness, with nuchal rigidity, no focal deficit, and normal fundus. So basically, our role here should be first of all to rule out the CNS infection, and as the fundus is normal, that means there is no papillary edema. So the first thing which we should do here is to perform a lumbar puncture. That is the first thing we have to do because they have already mentioned there is normal fundus which is present here. All of the following are true regarding causative organism of meningitis, congenital or acquired CSF leak, pneumococcal, absolutely right. Sickle cell anemia. Sickle cell anemia is associated with asplenia or hyposplenia because there can be autosplenectomy, and if there is asplenia or hyposplenia, there is increased incidence of encapsulated organism which particularly include Streptococcus pneumoniae. This includes Haemophilus influenzae B, and this includes meningococci. So this B statement is not correct here. If it is a T lymphocyte defect, basically it is Listeria monocytogenes, complement system C5 to C8 deficiency, late complement. This increases the chances of the Neisseria infection. Neisseria infection, that is the meningococcal meningitis. Sturge Weber syndrome is characterized by. Sturge Weber syndrome is the only neurocutaneous syndrome which is non-hereditary. Only only neurocutaneous syndrome which is non-hereditary. Yes, basically there is a port wine stain which involves the upper half of the face, not the lower half. And here, if there is port wine stain, on the same side, there is glaucoma. Congenital glaucoma, and there is also leptomeningeal angiomas. This leptomeningeal angiomas can cause cortical atrophy. They can cause cortical atrophy, which can lead to the seizures. So rest all the things can be particularly seen. Remember, it is the only neurocutaneous syndrome which is non-hereditary. It is due to the sporadic mutation. It is due to the sporadic mutation. Which of the following drugs is not useful in the management of status epilepticus in children? In status epilepticus, first therapy phase is 5 to 20 minutes managed with benzodiazepines. The second therapy phase 20 to 40 minutes managed with non-benzodiazepines, which includes fosphenytoin. Fosphenytoin, you can give sodium valproate and you can give levetiracetam. Right, you can particularly give is the levera, so-called levetiracetam. Right, these three drugs can be given 40 to 60 minutes. You want to give IV infusion of the propofol, midazolam, thiopenton or pentobarbital. So these are basically the drugs which are all required for the status epilepticus. This is required, this is required, this is required, but carbamazepine has got no role in the management of status epilepticus in children. Next one, a 5-year-old boy. A 5-year-old boy has been doing well despite being diagnosed as a case of TOF, but now the mother comes to you with complaint of acute febrile illness for the past 3 days. The mother is more concerned now as the child is complaining of headache for the past 12 years and is more lethargic than normal. Now, if you consider tetralogy of Fallot less than 2 years, you mainly get is the cerebral vein thrombosis. Cerebral vein thrombosis, and more than 2 years, basically what we get is the brain abscess. Brain abscess, right? Although this is very, very rare now, but in this question, if you particularly say a child of TOF having headache, lethargic, febrile illness, so all goes in favor of mainly brain abscess. So what should be done here? Basically, brain neuroimaging should be done here. All of the following CSF findings are present in tuberculous meningitis except yes, protein levels are increased, there is low chloride level, there is cobweb formation, but there is decreased sugar level because so many mycobacteria are present. They want to survive, they can consume the sugar. So what should happen to the sugar level? The sugar levels are basically decreased. Which of the following is not about breath holding spell? They start between 6 to 18 months of age, yes. And it is very rare to start after 24 months. There are basically two types of this. One is a cyanotic one is a pallid one. One is a pallid one. Cyanotic is basically after the child is crying. Why the child can cry? Because of anger, frustration or scolding. So this is after crying. And pallid is after pain which is there. In the breath holding spell and the absence seizure, there are 2 points of similarity, so-called brief lapse of consciousness in both, and there is no post-ictal confusion. There is no post-ictal confusion. So short period of drowsiness after spell, no. There is no post-ictal confusion. Rhythmic clonic jerking of the extremities, yes. Stiffening can be seen in cyanotic, but it is always seen in the pallid. And the treatment basically here is the parents' reassurance. The treatment here particularly is the parents' reassurance. A female child had menarche at 7 years. Menarche at 7 years becomes precocious puberty. Precocious puberty had multiple dark brown café-au-lait spots. The second finding is café-au-lait spots. There is bony lesion plus bony lesion. So if you consider like this, there should be two diagnoses you are having. One is NF1, one is the McCune-Albright syndrome. One is the McCune-Albright syndrome. Now, if in the NF1 there is the precocious puberty, it is due to optic nerve gliomas, and if optic nerve gliomas are there, there is visual difficulty which is present. Visual difficulty which is present. In McCune-Albright, there is as such no visual difficulty. So here it is given some visual disturbances. Answer goes in favor of the McCune-Albright syndrome, right? So this was some of the questions of the CNS which were important, right? Thanks for watching. Do subscribe to the channel for the more updates. Thanks.